So welcome. So Professor Andrew, thank you ever so much for joining us again. You've been an absolute stalwart this year. You've done a number of things for us. So we're always very grateful because your talks always go down really well. So I think I'm just going to hand over to you. And the reason for that is because I find it really hard to say this condition we're doing this on because my screen reader can't read it out properly. So
that's fine. Yeah.
Anyway, so good evening, Andrew. Thanks for joining us again.
Thanks, Colin. And yes, it's very nice to be working with the Macular Society again. It's one of my favorite charities, so it's a pleasure to be here. So I've been asked, I think, to talk on X-linked retinoschisis, which is a condition I see reasonably frequently in my clinics. And so I'm just really going to give a summary of the condition and and just talk about research and how we manage it at the moment. So this condition was thought to be originally described in 1898 with some beautiful drawings of the retina, which showed the classic appearance of splitting in this tissue at the back of the eye that senses light, the retina. And so the retina is like the photographic film in the eye, and in this condition there is a split in the middle of this photographic film, which is actually 3 different layers of cells in a sandwich, and there's a sort of a split in the middle of this layer. And when you look into a patient's eye with this condition, you see a cartwheel appearance in the very center of the back of the eye, and it's very characteristic in the early stages of the disease. And so retinoschisis just means a split in the retina, and it's called X-linked because the faulty gene is on the X chromosome, and that means that it's inherited and affects males and females differently. So males have one X chromosome and one Y chromosome. It's the Y chromosome that makes them a male, and they're affected with the disease. And females have 2 X chromosomes, and so they are carriers of the disease, but are typically not affected by it. So a male patient cannot pass the disease on to their son because they pass their Y chromosome on to their son, but not their X chromosome. But a male patient passes their X chromosome on to their daughters. So all their daughters will be a carrier of the disease, but not affected. And those daughters will have a 50-50 chance of either passing on their faulty X or their healthy X to their children. So if they pass on the faulty X to their sons will be affected. If they pass on their healthy X chromosome, the sons won't be affected. So there's a 50-50 chance they'll have a son unaffected or affected, and there's a 50-50 chance that their daughters would be a carrier or not a carrier. So you can tell, usually there would be a family history of sight loss in patients with this condition. Not always. It can spontaneously start in a male patient, and that can be the first patient in the family affected. But if you do have an affected male patient, that usually implies their mother is a carrier, and any sisters of that mother, so any aunts of that affected person, may be at risk of also having an affected child. So it's definitely worth thinking about genetic counselling for any family that has this condition. And it's estimated in various studies between 1 in 5,000 to 1 in 25,000 people have this condition. So it may present as this a sort of cartwheel appearance picked up by, say, an optician. May present with noticing that a child has reduced blindness, or sorry, reduced vision. It can present as early as 3 months of age, but let's say more typically, it's in the the first decade of life that it's noted. And vision initially might be reduced by 1 or 2 lines reading down a chart. In roughly 1 in 10 patients with this can have a complication of retinal detachment, and maybe 1 in 5 would have a complication of bleeding front of the retina, and that's called a vitreous hemorrhage. So some patients just have this central change, this cartwheel appearance that I mentioned. And about 50% of patients also have a split in the retina more peripherally. And that's not a retinal detachment, it's just a partial separation of the layers of the retina, but occasionally that can progress to a retinal detachment. So if it is detected in young children, they're often assessed, maybe on a yearly basis, up to the age of 10. And if just to look out for these complications that don't happen in everybody, of retinal detachment or bleeding in the jelly behind the eye, vitreous hemorrhage. And advice we'd give to patients to try to prevent complications is to avoid bangs to the head, so avoiding contact sports, wearing a helmet if they're on a bicycle, not doing bungee jumping, it just common sense stuff. For the changes in the center of the eye, the split in the retina that gives us cartwheel appearance in the cells at the very center, which look after our sharp central vision. It's been known for 10 years or more that there's a certain glaucoma drop that can make that separation of the layers less prominent, and you can get the structure of the retina looking more in a more healthy state by putting a drop called TrueSoft into a patient's eyes 3 times a day. And we don't have randomized controlled trials that this is absolutely the right thing to do, but there have been studies out to 8 years showing that vision improves on taking these drops. So I encourage patients to use this drop. It's a relatively simple thing to do. It can be tricky to get young patients to be compliant with this. It's, putting a drop in 3 times a day is tricky, but we do see that the patients who do that, the appearance of the back of their eye looks healthier than those who don't, and vision does seem to improve with this treatment. So vision in this condition, it can decrease between the first and second decade of life, but then tends to stabilize until patients are in their 60s, 70s, and then it may decrease a bit further. And it is variable how much it can affect people's vision. It can be just below driving level vision to more severe, not able to read many letters on the chart. So it is variable, and it's variable even within the same family. Like a lot of genetic conditions, it's very difficult to predict how severely people will be affected by this condition. So we know the gene that causes this. It's called Retinoschisis, named after the condition, and it seems to help stick all these layers of cells together so that they don't separate or split, and when it's faulty, they do split. So if patients aren't picked up when they have this cartwheel appearance at the back of their eye, if they're in their 20s, the cartwheel appearance may not be so obvious. And so you might do other tests to help you with the diagnosis. There's a test called an electroretinogram, which measures it's where we put electrodes around people's eyes and you shine a bright light at their eyes, and you can record the electrical pulse as light hits the eye, and how that electrical signal then travels through the different cells in the eye to the brain. And typically you get a bit like a heart tracing. You get an upswing in the tracing as it goes through different layers of cells. But in this condition, because of that split in the tissue, you don't get the upswing. So you get what's called an electronegative B wave. It's essentially, it doesn't rise up above the baseline. So that's one way you can help diagnose it. But because we know the gene, we can do genetic testing. And that's the definitive way to make a diagnosis. And we are actually, we don't usually, for genetic conditions, we often don't do genetic testing in children under the age of 18, if there's no benefit for that. But if a carrier female had a male child, who has a 50-50 chance of being affected or unaffected, we are starting to do genetic testing in male children of carriers to confirm whether or not they have definitely got the diagnosis, because that would affect how often we would see them in clinic and follow them to make sure they don't have complications. If they did have bleeding in the back of the eye and the jelly of the eye, if they did have a retinal detachment, these can both these complications can be treated with operations. So it is worth looking out for them. Finding the gene means that you can try to develop new treatments, particularly gene therapy. And so a mouse was made that has the faulty gene in it, and with replacing a normal copy of the gene in this mouse, restored the electrical function of the electroretinogram. So that test I mentioned, that it improved in mice who were given a replacement copy of this gene, which is done by an operation where you inject a virus that carries a normal copy of the gene under the retina, where it transfects the cells where the gene is expressed. So that's led to 2 gene therapy clinical trials in humans. Unfortunately, the results so far have not been as successful as in the mouse, and have been complicated with inflammation in patients' eyes when they've had gene therapy, and there hasn't been any real improvement with gene therapy as yet. And so more work at the moment is going on to understand in detail the function of the gene, to try to come up with a more effective gene therapy. Other things that can be done for patients is make sure they've got the right glasses, prevent the lazy eye developing, providing visual aids if needed, and of course, as I mentioned, using these drops that can help the structure of the eye. So it's a relatively common disease. With genetic testing, it's easier to diagnose now if you have a suspicion that might be the problem the patient has. And we have some treatment for it, but we would like to have better treatments. And I think there will be ongoing research into into gene therapy, learning from the initial trials. It might be changing the virus that we use might give less inflammation. It might be that we can alter which cells the gene is expressed in, which again might make it more effective. But yeah, I think most patients that I see come to see maybe every 3 to 6 months, where we do a retinal scan, which is non-invasive. It's just a few seconds looking into a camera, and that can show us all the layers of the eye, and we can compare it to previous scans and see how effective taking the drops are. And you know, it can be a powerful motivator for both children and their parents, if they can see the difference, not when they aren't so compliant with drops and when they are, in terms of how much better their retina might look. So that's kind of where we are with this condition at the moment. So I'm happy to answer any questions anybody has on that.
Brilliant, Andrew.
Yeah.
Thanks very much. I know we've had a couple of questions come through, so Jerry will hopefully do her usual thing and read them out. That would be cracking. So thanks.
Okay, a couple of connected ones from Edward. The medication you describe, is it prescribed off-label? Do people have to really? Is it hard to get hold of? I think.
No, it's not NICE approved, but it is off-label, and there hasn't been a randomized controlled trial, as I mentioned. But I don't, because it's a relatively cheap anti-glaucoma treatment. I haven't found there's been any issue about using it. I haven't really asked anybody whether I can or not use it, to be fair, but I really don't think there would be a problem. It is fairly standard practice, and you know, it doesn't have huge cost implications, so I don't really think I've never had any pushback from family doctors, for example, in terms of prescribing it. I don't think it's an issue. Yeah.
Good. How did they find out it worked? Did they just, somebody gave it a go? I mean, we say it hasn't been through a trial.
Yeah, it's a good question. It was so you can also get fluid gathering in another condition called retinitis pigmentosa, and it's been used in that condition, found to be effective. It's a drug that pumps fluid out of cells. I mean, there is a little bit of science behind this, a little bit of mechanism. But yeah, it was really extrapolation from one condition to another, and just trying it in some patients. I'm not 100% certain. There may have been some patients who also had glaucoma who it was observed it was effective in. But yeah, it was a little bit of luck, really, more than research.
Okay. Somebody else, can you repeat the name of the eye drop, please? I don't think I caught it either.
So TruSopt, TRUSOPT is the brand name. There's several variations. The generic name is dorzolamide, DORZOLAMIDE, and it's a class of drugs that are called carbonic anhydrase inhibitors. So, so yeah, it can sting a little bit. You know, so some people might find it a little bit uncomfortable. I think you can get a preservative-free version of it. But yeah, I mean, it probably doesn't work in all patients, and you know, it's really just for that central splitting of the retina. But I think it's definitely worth trying in all patients. You know, for at least 3 months, just to see if it will help. And you can, as I say, you can assess it by looking at retinal scans and measuring vision as well.
So if it does work, do you need to take the drops for life?
I think so. In the same way you do for glaucoma. Yeah, absolutely.
It's interesting because
you would, as I say, you would keep monitoring patients if the split went away. If it completely went away, you could probably stop and just see what happens. But you would, so there's a little bit of trial and error. But if there was absolutely completely resolved the splitting of the retina, you can tentatively stop it and just see if it stays reattached. But yeah, it's empirical.
Okay, thank you. Does the condition make eyes sensitive to light?
I mean, a little bit, but it's not a huge symptom for patients. It's usually different. I mean, the condition that mostly makes people inherited retinal conditions, cone dystrophy, which typically causes the most problems with sensitivity to light. So I should say not, in most people it doesn't. Yeah.
Okay. Related to the gene therapy and the use in mice, it's a fundamental question really, how good a mouse model is compared to being a human. So why would there be a difference in human and mice? I mean, mice don't have a macula, do they?
Mice don't have a macula, and that is a huge limitation. It's very different to humans. So not all treatments that by any means that work in mice work in humans. And that is an issue, that they having good models of that will translate from animals to humans. So sometimes it works, but I mean, mice are convenient because it's relatively easy to make a genetic, to modify a gene in the mouse to replicate the disease that you see in a human. And sometimes the appearance in the mouse eye is very similar, so that you do get splits in the mouse retina, in the retinoschisis mouse, similar to what you get in humans. But yeah, it doesn't always translate. And certainly for another condition I'm do a lot of work on, which is macular degeneration. That's tough because mice don't have a macula, as Geraldine said, this very sort of central area of the eye which doesn't have any blood vessels. So yeah, it's a first step, but by no means guaranteed. That's why we still have to do clinical trials in humans to evaluate whether these potential treatments work or not. For the licensed gene therapy that we have for another inherited retinal condition, Leber's congenital amaurosis, due to mutations in the RP65 gene, there was a dog that naturally had the same eye disease. So it wasn't created in the dog. That would be very difficult to do, but there was a dog that just through nature had mutations in the same gene, and so the work was done on that to show it was effective, and then that translated the gene therapy in humans and was equally found to be effective. So sometimes you're lucky and there's say a dog that has the same disease as humans, and that might be easier to assess in a more accurate way that it's going to be effective. Saying that, dogs don't really have a macula either, so
it's just primates. Is that correct? Yeah.
Primates and birds of prey.
Birds of prey. Oh, okay, I've heard that one. So I'm wondering, has anybody tried to create a stem cell based model from patients who actually have the condition? I know they're doing that with AMD and things.
Yeah, I'm not aware of that, but it would be easy. It could be done. You could, and that might be the next step. So creating what's called retinal organoids, where you take, for example, a skin biopsy from a patient and convert those adult cells. You can use different chemicals to convert those adult cells from a skin sample, say from a little bit of skin from the elbow, convert that back to stem cells, and then get them to differentiate into eye tissue, and so we do that for other conditions. So potentially that could be done. The challenge is trying then to think of how you would assess that a treatment's effective, because it's you can't really, it's not like injecting a gene therapy into the back of a mouse eye. You just have some cells in culture, and so possibly you can measure the electrical response of the cells to light with and without treatment, but there are pros and cons. It's just trying to prove that a treatment's effective. But there are things you could do with it. You could understand the structure of the protein much better, probably from stem cells looked at in that way. Yeah.
I think no model's perfect is the answer, isn't it, really?
Unfortunately not. That's the challenge. Yeah. I think, yeah, I would expect that there will be further attempts at gene therapy, because it's not that uncommon a condition. I mean, one in 5,000, 1 in 25,000. That's not that uncommon. So there is an unmet need there for better treatment.
Is it something that would be picked up by an optician? They would recognise that.
Yeah. So it can be really mild at the start, and so there might just be this funny appearance in the back of the eye, this sort of cartwheel appearance. So so maybe, yeah, and so sometimes it's picked up around between the age 10 and 20. Sometimes at 20 to 30, someone has a little bit of reduced vision, and that's when they would come to the eye department. And there may be a history of vision problems in the family, which would also be something that would make you want to think about genetic testing.
Thank you. Somebody's put quite a long comment in. I don't know if you can see it. I'll read it out.
I can.
It's about his son has a retinal attachment.
Yeah.
Since he was 3 years old. He's now 7. He has band keratopathy, I'm not sure what that is, and EDTA chelation. And the person is yes, basically looking for advice, which I know is quite difficult in this sort of situation, but I don't know if you can offer anything.
Yeah, so it sounds like one eye had a lot of complications of retinal detachment, and if an eye becomes small and what's called physical, if it's sort of, then you can get calcium forming on the front surface of the eye, and it can be uncomfortable. And I think that's why this poor guy's had a lot of sensitivity to light, because if the front surface of the eye, which has lots of nerve endings, is damaged, that can make your eye very sensitive to light. And so he's having treatment to try to remove that calcium. And as I said, this has been done relatively recently, so it's perhaps a little bit early to say. He's covering his good eye. Yeah, I'm not sure why he's covering his good eye, except maybe just to see what sights in the poor seeing eye. In terms of waiting or doing something else, I mean, I think this is a problem with the front surface of the eye, the cornea, which, you know, that it's slightly beyond my area of expertise, corneal problems. I think, from as far as I'm aware, this EDTA chelation is probably the best thing to do initially, but it's really what the corneal specialist would say would be the next step. I think that probably is in general, that is the accepted treatment, but it's a slow process, because essentially it's a chemical reaction penetrating through different layers of the cornea, so it might take some time.
Thank you. I was wondering, does it affect any other parts of the body?
No.
Only affects the eye.
Yeah, and the protein is only expressed in the eye, and that's one of the challenges in trying to understand its function. It's mostly expressed in the cells, essentially, the photoreceptors, and it's not. Yeah, so it's not expressed anywhere else. So it's interesting. Its function is not fully known, and that's part of the challenge in developing therapy. It forms the multiple proteins come together to form a complex, and so you have to get different building blocks of this protein all working together. And again, that may have been a problem with the gene therapy, that it didn't get that connection of 4 or 6 blocks of the protein all working together. So there's a lot that still needs to be unpicked, why it as yet has not been effective.
Mm-hmm.
Yeah.
And a question I missed earlier, are both eyes affected the same?
Yeah, it's like most inherited conditions, that's another clue as a doctor, is that you expect it to be in both eyes. So it's usually very symmetrical between the eyes. You can get, so I'll backtrack a little bit and say the central changes are symmetrical, like cartwheel appearance. Just as what we're talking about, one eye might be more severely affected with a retinal detachment, and that's not symmetrical. So you may have poor vision in one eye and still have good vision in the other eye, and that can stay like that for indefinitely. The one thing about children is they never seem to tell you when they have a problem with their eyesight, and they never complain that they've lost vision in an eye, and that's one of the reasons that we need to keep checking them, because it's amazing how they can tolerate a complication in one eye, and they won't volunteer that information unless you go and check them out. So yeah, so we need to keep monitoring.
If you can detect a problem, do they then say, "Oh yes," and they sort of acknowledge it then, or is it just that they're really not managing
they don't
really well?
notice it. They don't. I mean, well, it's the problem, I guess, with older patients is, I think it's more with younger patients, like children, but in the same way, patients with macular degeneration, elderly patients, often don't notice a problem in their first eye because their second eye fills in the gaps. But it's even more so with young children. They just typically don't volunteer that information. I guess if you push them, they would admit it. If you cover up their good eye and say, "Oh yeah, something wrong there," but generally they can tolerate reduced vision for a long time without anybody noticing. And of course, if you,
I can concur with this. I can barely remember. I'm very old. When I was 8 and my Stargardt started to affect me, I really didn't accept the fact. I was just still seeing stuff, so it didn't really make any difference. It was only that I started getting closer and closer to the TV, and my brother and sister weren't, and I didn't understand why they weren't. So you just sort of, as you say, Andrew, you sort of get on with it when you're a kid, because you don't know any different, because it's your eyes and you're seeing through them, and you don't understand what other people see. So it's hard to sort of make a difference between the two.
Yeah. Embarrassingly, I didn't notice my daughter was short-sighted and needed glasses until she was about 10. and then when she did get glasses, she said, "Oh, I didn't know you could see leaves in trees." You know,
Yeah.
I've never told us that. Yeah, that's leaves in trees, but it was slightly embarrassing that I hadn't noticed that she was her long distance vision wasn't good. So yeah.
It's
So
like
we won't tell anyone, I promise.
you get a new pair of glasses and you go, oh, isn't that everything's so clear? You know, it's HD. Yeah,
exactly. Yeah, you don't know what you're missing until you've got it correct. Yeah. So I mean, because it's a as I say, relatively common inherited disease, there's definitely ongoing research into this problem, and I hope that we do come up with a more effective gene therapy. But at the moment, it's not there yet.
Thank you. We haven't got any more questions in the chat.
We haven't got any more questions in the chat, and I don't have any questions either. Jerry, have you got any?
I've run out.
You've run out as well. I'm not embarrassed to say it appears we may have come to a natural end. So I think everybody's happy. If anybody's got any other questions, chuck them in the chat quick while we're waffling on. So Jerry, just a quick word with you then. So we're starting to think about our sessions for next year, aren't we? So we're always after people to come along and talk. So just sort of, if anybody listening or watching this has any sort of anybody they can think of that we can come and do a session because they know them, because they see them personally, or as a patient, and they're up to some stuff, if they just want to let us know, we'd be very grateful, wouldn't we? Wouldn't we, Jerry?
Yes, we would.
So I think someone's just dropped a question in the chat.
Yeah, another great session from a subject matter expert. Thank you very much. Thank you and happy Christmas. That's one. Thank you. Happy Christmas to you. Is it too early to say that? And the gentleman with the son with the retinal detachment asking for if there's a doctor who could deal with this condition anywhere, a corneal specialist.
Maybe. I don't know where they're based, but I mean, I would typically suggest, any, big eye department should be able to deal with this. Perhaps one affiliated with the university would have subspecialists in inherited retinal diseases. So there's big centres in most cities in the UK will have a good eye department. Like in Manchester, Liverpool, Leeds, Bristol, for example, all would have experts who could help with this. It just depends on your location in the country, or talk to your GP, who would probably be able to refer you to a local specialist. But there are generally, most big towns would have a retinal specialist who specializes in this condition.
Thank you very much.
Okay, well, Jerry, so I was just going to say about our researchy stuff. We've got bits and pieces coming up, haven't we? So if you want to sort of talk about that for a sec, and then we shall all go and have an early glass of wine. I think that sounds like a plan.
Absolutely, thank you very much. Yes, so we have a programme of research projects that we fund ourselves as a Macular Society, but we also support researchers around the country, and we support them partly through helping them find patients with specific macular diseases, They don't only want patients for clinical trials and clinical studies, they often want patients to give the benefit of their experience of living with a macular disease, to be on a committee or a focus group or a panel. And so if anybody's interested in doing that, we suggest you sign up to our what we call our research participant database, which you can find a sign up form on the research section of our website. And that enables us to have a few details about yourself, nothing very extensive. And if we get approached by researchers who are interested in finding people with that condition, we would get in touch with you and give you some information. And it's entirely up to you whether you volunteer to take part. It may be too far away for you. You may want to travel, long distances. Other people are very happy to travel to the ends of the earth to take part in research. But it's a lot about taking part in clinical trials or studies, but it's also patients have the opportunity to become involved in research in a number of other ways as well, rather than just being sort of guinea pig on part of a trial. So it's incredibly important for researchers to have patients involved in their studies from every stage through planning, conducting the research, and then sort of reporting on it at the end. So we do get a lot of requests to support research in that way. And we have a lot of information on our website. We have webinars like this. We have our annual conference, and you can always put in an inquiry and we'll do our best. Or if we can't help, we might put you in touch with somebody like Andrew to support and find that information that you need, particularly with the rarer conditions, because we realise that getting access to a specialist is really important in those situations. Thank you.
Perfect. Well, thank you. That's brilliant. So we have come to the end of our 11th and final webinar, Macular and Me webinar for this year. I just want to say thank you, because I know there's a couple of people here this evening that have joined us this evening that are pretty much, apart from when they've been on holiday, have attended most of our Macular and Me sessions. So really thank you for supporting the Macular Society with this. This is it's a really good part of our service now. We're looking to sort of continue it into next year. It's really a good way of getting that information out in a very clear, concise way with leading researchers and clinicians like Andrew this evening. And we just keep doing that on both streams, obviously, because there is the AMD stream as well, run by Kathy Yelf, our CEO. I am happy to say the next one of these will be on January the 26th, after the C word, and after we've got through Christmas and over our hangovers, and you might have to put up with me. I've decided to do one of my legendary welfare benefit surgeries. So we're going to talk about all things welfare benefits, cost of living crisis, energy stuff, and anything else I can think of within an hour. And it's going to be a free-for-all. In my little bonds, I have quite a lot of information. I'm a welfare rights officer by skill and by trade. So come bearing lots of questions, and I hope I can answer them. And if I can't, I can generally find the answer later. So anyway, that's on the 26th of January. And it just leaves me to say thank you again. Have a really good Christmas, a festive period. Look after yourself, stay safe, and try and keep warm. And have a good Christmas, and we'll see you in the new year. Thanks very much.
Thanks, everybody. Goodbye.